بسم الله والصلاة والسلام على سيدنا محمد وعلى آله الطيبين الطاهرين وأصحابه المختارين. السلام عليكم ورحمة الله وبركاته. This is considered to be continuation of our serial lecture about hypertensive disease in pregnancy, and what we are going to discuss today is HELLP syndrome. HELLP syndrome, it's a disease diagnosed as H stand for hemolysis with microangiopathic blood smear. E stand for elevated liver enzyme, and L stand for low platelets count. HELLP syndrome affected 70% antenatally, 30% postnatally. Out of this 70% antenatally, 80% occur before 38 weeks, and 20% occur after 38 weeks. 3% occur before 20 weeks of gestation. What is the risk factor of HELLP syndrome? We know that previous history of preeclampsia or HELLP syndrome predisposing the patients for recurrence of HELLP syndrome with 7%. As we note that the relationship between HELLP syndrome and severe preeclampsia is controversial. Some scientists, they do believe that HELLP syndrome is one form of preeclampsia, severe preeclampsia, where the other, they believe that the HELLP syndrome is separate disorder from preeclampsia. But we have to keep in mind that 15 to 20% of patients with HELLP syndrome, they don't have any high blood pressure or proteinuria. Other risk factors like mutations in complement regulatory protein, and there is also association, but less than 2%, with a fetal long chain 3-hydroxy-CoA dehydrogenase deficiency. As we know that the nulliparity is not a risk factor for HELLP syndrome. Pathogenesis of HELLP syndrome. We know that HELLP syndrome is systematic inflammatory disorder, and the complement cascade is the key mediators. As long as we also know that the severe form of preeclampsia can be presented as HELLP syndrome, but for one reason or another, there is diversion along the different pathway for unknown reason. So this create a greater hepatic inflammation and greater activation of coagulation system than preeclampsia. Other things which can be presented in HELLP syndrome: microangiopathic and activation of intravascular coagulation, and hepatic histology may show microvascular fibrin deposition, neutrophil infiltration, and fatty infiltration, lobular necrosis, and periportal hemorrhage. What is the sign and symptom of HELLP syndrome? Sign and symptom of HELLP syndrome. We will present them by percentage. 86 to 100% of HELLP syndrome patients, they are presented with proteinuria, whereas 80 to 80% presented with high blood pressure and what we are calling hypertension. And we are calling hypertension if blood pressure is exceeding 140 over 90 millimeter mercury. Also, 80 to 90% of the patients presented with a sign and symptom of hepatic involvement, like right upper quadrant and epigastric pain. We have around 30 to 84% of the patients presented with nausea and vomiting, and 30 to 60% presented with headache, 10 to 20% presented with visual disturbances, and 5% presented with jaundice. By looking to this percentage and looking to the sign and symptom of HELLP syndrome, it's look more or less similar to the sign and symptom of severe preeclampsia. Not only the HELLP syndrome presented with headache, hypertension, proteinuria, nausea and vomiting, and epigastric pain, but it also can present with serious maternal complications. And this could be like disseminated intravascular coagulopathy, abruptio placenta, and acute kidney injury, pulmonary edema, and subcapsular or intraparenchymal liver hematoma, and retinal detachment, rarely can presented with the hematuria, petechial hemorrhage, and ecchymosis. As we mentioned that around 15 to 20% of the patients with HELLP syndrome presented without proteinuria and without high blood pressure. So any patient presented with upper epigastric pain, nausea and vomited, general malaise should be investigated thoroughly to exclude HELLP syndrome. This investigation will divide them into basic investigation and further investigation. So the basic investigation should be complete blood count, peripheral smear, aspartate aminotransferase, alanine aminotransferase, bilirubin, creatinine. If there is elevated liver enzyme, then one step further will be taken and haptoglobulin, lactate dehydrogenase level, and coagulation study like fibrinogen, PT, APTT should be measured. This will lead us for the second question, which is what is the criteria for the diagnosis of HELLP syndrome? We know that HELLP syndrome is presented H for hemolysis. So hemolysis will be established by at least two of the following: peripheral smear, schizocytes and bar cell, serum bilirubin more than 1.2 mg per deciliter, which is equal to 20.52 microgram per liter, low serum haptoglobulin less than 25 mg per deciliter, lactate dehydrogenase more than 600 international unit per liter, which is 2 times the upper level of normal, severe anemia unrelated to blood loss. The other one, elevated liver enzyme, we will look for the AST and ALT, and they should be more than 2 times the upper level of the normal. And when we are talking about low platelets, we are talking about platelets less than 100,000 cells per microliter. American College of Obstetric Gynecology put their diagnostic criteria as the 3 things. Lactic dehydrogenase, it should be more than 600, AST/ALT elevation more than twice the upper limit of the normal, and platelets count less than 100,000 cells per microliter. When we scope our investigation and look deeply into LDH, lactic dehydrogenase, total bilirubin, and haptoglobulin, and let us look for each one. Elevated LDH level is non-specific marker that can be associated with severe hemolysis and with acute hepatocellular injury or with both. And if you look to the bilirubin level is increased as a result of increase in the indirect unconjugated fraction from hemolysis, and this is also could be increased to any other reason rather than hemolysis. So neither LDH nor bilirubin, indirect bilirubin is specific. But what about haptoglobulin? Haptoglobulin level is a specific marker of hemolysis, 25 mg per deciliter, providing the best cutoff between hemolytic and non-hemolytic disorder. Some authors subclassified HELLP syndrome according to the platelets count. So they classified them into class 1, class 2, and class 3. In class 1, the platelets count will be less than 50,000 cells per microliter, plus lactic dehydrogenase more than 600 international per liter, and AST/ALT more than 70 international unit per liter. Where class 2, it is for LDH and AST, it is the same, but the platelets count will be more than 50,000 but less than 100,000. The class 3 platelets count more than 100,000 but less than 150,000. With all the criteria, whether class 1 or 2 or 3, all of them, they have LDH more than 600 and AST/ALT more than 70 international units per liter. This slide is considered to be one of the most important slides in our presentation. It is the differential diagnosis of HELLP syndrome. We mentioned that we consider some of the authors, they will consider HELLP syndrome to be part of the severe preeclampsia. The other, they will consider it to be a separate entity. But believe me, to differentiate between HELLP syndrome and severe preeclampsia is not an easy issue, but it is not as difficult as to differentiate between HELLP syndrome and acute fatty liver of a pregnancy, or with thrombotic thrombocytopenia purpura, pregnancy-related hemolytic uremic syndrome, and systematic lupus erythematosus flare-up. Why it is important? Because some of these diseases, they have different modality of management which can save the patient life. So whenever you have a patient with HELLP syndrome, you have to exclude these diseases to be able to manage the patient appropriately, so reducing the maternal mortality and morbidity. Looking to the acute fatty liver of a pregnancy, we are talking about a disease causing hypoglycemia. It can cause fibrinogen level less than 300 mg per deciliter and prolonged PT, APTT, and elevated creatinine. Why we are considering concern about this? Before we are talking about our concern, we will say that the appropriate diagnostic tool, it is liver biopsy, which is not carried out. One of the study of the acute fatty liver of a pregnancy, they found that 50% of their patients fitting the criteria of HELLP syndrome. So it's not an easy to differentiate between the two. Many patients, they have hypertension. Many patients, they have proteinuria. So the existing of preeclampsia can make the picture more foggy and more vague. So hypertension is more common in HELLP syndrome rather than acute fatty liver. Despite the initial management is the same, but it's important to diagnose acute fatty liver because it might deteriorate rapidly and liver failure might occur, hepatic encephalopathy might occur, and severe hypoglycemia might occur. So presence of fibrinogen level less than 300 mg with hypoglycemia, we will keep it in our consideration when we are talking about acute fatty liver versus HELLP syndrome. What about thrombotic thrombocytopenia purpura and HELLP syndrome? AST, ALT are minimally elevated in TTTP. LDH level are markedly elevated more than 1,000 international unit per liter and as high as 2,000 to 3,000 international unit per deciliter, where LDH in HELLP syndrome can reach high up to 1,000, but it is unlikely to be more than 1,000 international unit per liter. The percentage of schizocytes and on the peripheral smear, it's in the TTP, it's as high as 5%, where it is less than 1% in HELLP syndrome. Look to the PT and APTT, they are normal in TTTP patients and can occur early in the first trimester. So the time of the occurrence of the thrombotic thrombocytopenia purpura, it can occur in any gestation and it's unlikely to present it in the postpartum. Comparing to acute fatty liver, which is might occurring in the second and third trimester and up to 5-day postpartum, but unlikely to be presented early in pregnancy. Pregnancy-related hemolytic uremic syndrome, the patients develop it mostly postpartum. It has thrombocytopenia and hemolysis. It has kidney injury is prominent. And AST, ALT not highly elevated. Remember that hemolytic uremic syndrome, it's a serious disease. The patients might require dialysis, and it will be life-saving procedure. So in acute fatty liver, there is supportive treatment. Patients might require ICU, TTP, the patient will require a plasma exchange, and it is the solution in the management. Pregnancy-related hemolytic uremic syndrome, we are talking about dialysis. When the systemic lupus erythematosus flare-up, there is hemolytic anemia, is relatively rare. Mild thrombocytopenia, the platelets count between 100,000 to 150, rarely to go severe like what is going on in HELLP syndrome. Liver enzyme, it won't be highly elevated in flare-up, in SLE flare-up. In SLE flare-up, it occurs more toward postpartum. So we have two of our differential diagnoses. They are occurring in the antenatal. Two of them, most of them occurring in the postnatal. So hemolytic uremic syndrome is occurring at the end of the trimester and mostly presented postpartum. Systemic lupus erythematosus mostly presented in the postpartum. Acute fatty liver and TTP, they are presented at any gestation, but remember that acute fatty liver, it occurs more toward the second and third trimester, where TTP can occur even in the first trimester. To be able to detect these diseases, you can use the appropriate modality of management and treatment in this disease. Going from the most serious 5 differential diagnoses of HELLP syndrome to the second line differential diagnosis of HELLP syndrome, which is the other causes like epigastric or upper abdominal pain in pregnancy, including gastroenteritis, hepatitis, appendicitis, cholecystitis, pancreatitis, and pulmonary embolism. Why I put it the second differential diagnosis? Because it is not it's not a difficult entity like the previous 5 differential diagnoses of the HELLP syndrome. By remembering that none of these disorders associated with thrombocytopenia, this is one could exclude the other which is interlinked with HELLP syndrome. We know that acute viral gastroenteritis is associated with fever and diarrhea. Hepatitis can be easily diagnosed with serological tests. Acute cholecystitis, always the patients they having history of recurrent visit to the emergency room due to the symptomatic gallstone. And at the same time, the patient can be presented with fever, leukocytopenia, and typically developed in those patients with a history of gallstone disease. Acute pancreatitis, the patient is associated with epigastric pain radiating to the back, and there will be elevated in the serum lipase and amylase. And this elevation in these two amylase and lipase could be 3 times greater than the normal value. In patient with pulmonary embolism, characterized by dyspnea, pleural chest pain, and characteristic finding could be identified by the imaging study. Management of patients with HELLP syndrome. So we already diagnosed the patient with HELLP syndrome, and we will see, is this patient require urgent assessment or intervention, or this patient didn't require an urgent assessment and intervention. For the first category, which require urgent assessment and intervention, it will be for the woman with severe hypertension, woman with an abnormal fetal heart rate tracing or low biophysical profile, woman with severe right upper quadrant and epigastric pain where are suspected subcapsular hematoma or hepatic bleeding, woman with DIC, pulmonary edema, or acute kidney injury. For the second category, who didn't require immediate urgent assessment and intervention, like administration, of course, corticosteroid will be appropriate for the patients. We can conserve the patients for 48 hours. You can start her, and she's not severely hypertensive, on magnesium sulfate, and wait for 48 hours for the lung maturity and deliver her after that. Look to this beautiful flow chart created, and I just adopted this flow chart from the UpToDate. Management of patients with the diagnosis of HELLP syndrome. We can administer magnesium sulfate for the seizure prophylactic and treatment of the severe hypertension at the first line whenever you diagnosed HELLP syndrome. So if the patient hypertensive, give her antihypertensive. If she is not hypertensive, give her magnesium sulfate for prophylactic. Because we said that HELLP syndrome and severe preeclampsia, they are interlinked together and could lead to the eclamptic fit. So if the patient is the gestational age below viability or more than 34 weeks, then you deliver the patients. If the patient is not below viability and not more than 34 weeks, look to certain questions to be answered. Is there any non-reassuring fetal testing or fetal heart rate or biophysical profile? If there is a fetal death, abruption placenta, pulmonary edema, eclampsia, hepatic bleeding, stroke, acute kidney injury, or DIC. So any of these criteria, you answer it by yes. That means you are jeopardizing the patient life as well as the fetal life. Since the fetus is achieving maturity, there is no time whenever the patient is eclamptic or pulmonary edema or stroke for the time for administration of corticosteroid, then proceed for the delivery according to the situation. If the patient is answered by no, then you still have a time to deliver the patient within 48 hours, administer a dose of corticosteroid. Management of patients with HELLP syndrome. Women with severe hypertension or women with abnormal fetal heart rate tracing or low biophysical profile score will be managed as a patient with severe preeclampsia with any of these features. Whereas the woman with a severe right upper quadrant epigastric pain or women with a DIC will be managed separately. DIC should be managed in intensive care unit with multidisciplinary team where hematologists should be involved and anesthesiologists. So if a woman presented with the severe right upper quadrant or epigastric pain, you have to keep in mind that this patient, she might have hepatic bleeding, hepatic swelling, subcapsular hematoma, which is occur around 1.6% of HELLP syndrome, impending liver rupture, or intraparenchymal hemorrhage. Remember that the patients will be presented with severe right upper quadrant pain and abdominal pain and either shoulder pain, neck pain, hypotension. The aminotransferase in these women, it's usually modestly elevated, but a value of high level of aminotransferase up to 4,000 to 5,000 international units per liter can occasionally be seen. So how we approach these patients? The diagnostical test will be CT scan or MRI. We know that CT scan and MRI not all the time available, so the clinical picture, breast ultrasound and expert hand can do cover for the deficiency of or absence of MRI and CT scan. So how we will approach this patient? We have to stabilize the patient. We have to transfuse the patient if she's in shock, hypotensive, tachycardic, resuscitate the patient, start blood transfusion, disregarding whether this fetus is having, if the fetus is having any non-reassuring fetal heart rate pattern or abnormal biophysical profile. Priority is to resuscitate the patients. Once you resuscitate the mother, the fetus will be resuscitated. Then you proceed for the operation. Remember that to call the team, that the liver trauma team should be called and should be available. And assuming that you are working in a center where the team of the liver trauma is not available, then you call the surgeon and you have to open your patients once the patient is stable. The surgeon, what they can do draining, backing, hepatic artery ligation, resection of affected area of the liver, stabilizing the patients or backing the patient and send her for tertiary center is an alternative modality of approach. Once you diagnose the patients with HELLP syndrome, follow up the patients with HELLP syndrome require repeated investigation every 12 hours, blood transfusion policy, conserving the blood transfusion unless the hemoglobin is less than 7 mg per deciliter or the patients have ecchymosis, severe hematuria, or suspected abruption. What about platelets transfusion? Platelet transfusion policy, if a patient is approaching vaginal delivery, so the platelets count should be more than 20,000 cells per microliter. If a platelet is less than 20,000 cells per microliter, for a vaginal delivery, we should receive a platelets transfusion. And if it is less than 50,000 cells per microliter, for cesarean section to prevent the bleeding. Mode of the delivery should be vaginal delivery unless there is an obstetrical indication for cesarean section. Remember that if you are going for cesarean section and you suspected liver hematoma or any liver abnormality, so midline incision is the best incision suggested. So the cardiovascular or the hepatic surgeon will be able to approach the patients without excessive another incision. So there is no strong evidence suggesting the use of dexamethasone for maternal causes. Dexamethasone conserving for patients less than 34 weeks with HELLP syndrome to enhance lung maturity, but not to treat the HELLP syndrome. Follow-up of patients with the HELLP syndrome postpartum. We are expected to repeat the investigation every 12 hours postpartum till the investigation back to normal. What is expected from HELLP syndrome to have initially worsening within the first 48 hours following the delivery, with a dropping in the platelets count decreasing by 40% per day and the hematocrit fall and liver enzyme increase. Expected to have normal platelets count in the day 4 postpartum. If platelets continue to fall and LDH rise after the 4th day postpartum, we have to search for another cause. So the lowest observed platelets count occur at a mean of 23 hours after delivery. After that, after 48 hours, start to improve. With supportive care alone, 90% of the patient with HELLP syndrome will have platelets count more than 100,000 and reversed trend decrease in liver enzyme within 7 days. So in HELLP syndrome, increased serious morbidity is associated with marked elevation of AST more than 2,000 international units per liter and lactate dehydrogenase more than 3,000 international units per liter. This serious morbidity could be mental status distortion, jaundice, intense hemolysis, extreme hypertension, multiple organ failure, and up to death. When we counsel the patients postpartum after the recovery regarding the HELLP syndrome, we have to keep in mind that the risk of recurrence is 7% in subsequent pregnancy, and we have to warn the patients, and we have to tell her also, since the severe HELLP syndrome considered to be form of severe preeclampsia, low-dose aspirin for prevention of preeclampsia and HELLP syndrome might work.